Okay, so good morning all, and I want to know about the audience. How many of you are infection control officers and nurses here? Can we have a raise in hands? Wow, great. So it's the perfect audience. I think I have the perfect topic because this is core infection control topic which will be difficult for others to understand. It's about methodology, auditing, tools. So if you're already practicing it, you will be able to correlate what you're doing. So I'll be talking on surveillance methods for healthcare-associated infections. Most of the things are practical tips with the checklist. Okay, so for the next 20 minutes, we'll be talking on what is surveillance, why do we need to do surveillance, how to do surveillance, and when to do surveillance. That's more important, like how to interpret the data of surveillance and use it effectively for clinicians. We can't just collect data for NABH or for any other quality purpose. It should be helpful for the clinicians and to correlate with patient outcome. So what is surveillance? I think we all do a lot of audits like hand hygiene audits, IPC audit, BMW audit. So audit is something we see what's happening in the time frame. You go to an ward, for 10 minutes you see what's happening. There may be 100% complaints in the daytime. When you go at the night time, it will be zero. So that is the drawback of audits. But when we look at surveillance, surveillance is a continuous process. Like how a CCTV captures everything 24/7, like that a surveillance should capture everything 24/7 by means of a validated audit tool, either in the form of LIS or HIS integration or a manual picking up of data. So how to do it, that's depending upon your setup. But there is a good difference between audit and surveillance. Please remember, surveillance is what you continuously monitor and you get the data, you analyze and interpret the data. So that's about what is surveillance. Why do we need to do this HIA surveillance, especially in India? I think there was a talk yesterday by WHO IPC unit head Benedetta ma'am. So I think she would have projected these two slides. So one is about HIA prevalence. So when you have to talk about the prevalence of infections or incidence of infections at a global level, at a national level, or at your own institute level, you need to have data. How to get this data? Only when you do surveillance. So as you can see, in African countries and Southeast Asian countries, like us, we are in India, which belongs to Asia, so our prevalence is very high. But to me, it is actually under-reporting because lot of the smaller setups are not doing surveillance. So the 12.9% data could be an under-reported data, which could be more than this also. And globally, when we look at, you can see the red dots, the bigger dots, which means the AMR infections are very, very high in the Southeast Asian region. So if we do not have a data, the policy makers will be having trouble on how to implement, what to implement to target a milestone. It's very difficult. So surveillance becomes the key to make a policy, to change a policy, even for an AMSP point of view. So I think you all know about this study by Dr. Puva Mathur and et al. This is an Indian data. So if you are already working in infection control, till 2019, we did not have an internal benchmark. So like even when NABH comes, they'll be asking you to keep a benchmark. So we always keep CDC as our benchmark, ECDC, Dr. Victor Rosenthal's paper as our benchmark. So this is now our benchmark. We have a data in India collected from very good tertiary setups across India. This is published in Lancet by Dr. Puva Mathur et al. I'm not going to read out everything. You can go through this paper. If you want to compare your CLABSI CAUTI rates, you can use this as an internal benchmark. So where are these infections, HIAs, come from? Okay, only if you know where it is coming from, you can target the interventions. So one is patient, that is endogenous source. So the patient's own commensal, especially for MRSA infections, it's a patient's own commensal. I think in the previous talk, we talked about decolonization, we talked about removing rather than using antibiotics. So that's where the endogenous source becomes an infection. Next is the trouble, especially in India, because of overcrowding, improper cleaning. I think there was a question in the morning about how to clean ventilators, because cleaning becomes a big challenge. So exogenous sources like patient care, equipments and devices, like we had a talk on endoscopy, which could be a problem for atypical mycobacterial infections. A lot of troubles comes because of improper cleaning and decontamination. So this is the source, and we target mostly on 4 healthcare-associated infections in India. One is surgical site infections. Second is ventilator-associated events or pneumonia. Third is central line-associated bloodstream infections. Fourth is catheter-associated urinary tract infections. There will be no definitions. I'm not going to teach you on the CDC definitions. We'll be just going through a rough ideology of how to do surveillance. If you are a new hospital, or if you're just going to start surveillance in your unit, or if you want to improvise your surveillance, always follow this flow diagram. The first is you have to meticulously plan. We can't just start surveillance just like that. You have to have an infection control committee. You have to involve your intensivists, the nursing superintendent, the ICNs. Everyone should sit together. Let's say, for an example, you want to capture FiO2 peep value. Where to capture? Does your case sheet document it? Do you have an automated way of pulling out this data in your clinical workstation or HAS? First, go through every bit of formulas and documentation that you need, whether it is being captured in your HIS. So just go through that. Then you teach your infection control nurses. So the data collection starts with infection control nurses. Train them, validate whether they are collecting it properly. So how to do the validation? Maybe the infection control officer can go and cross-check around 10% of the data initially. Once they are competent enough to do the data collection on their own, then let them do it. Then you do the analysis. So let's say if you think that it is a ventilator-associated events, as most of the infection control professionals are microbiologists, it's better to talk to the intensivist and radiologists and clinically correlate whether it is really a VAE or not. So then only you can come to a consensus that it is a VAE or CLABSI or COTI. So analyze it and interpret whether it is a CLABSI, COTI or VAE and communicate. Very, very important. We can't collect data and keep it in our HIC office. We have to communicate that this is a VAP, this is a CLABSI to them. And then you have to do a root cause analysis of why this is happening. So how to do this? Surveillance. So there are different types of surveillance. One is active surveillance. This is the ideal method. So an active surveillance is every day the infection control nurse goes to the ICUs, collect the data prospectively. So they collect all the clinical parameters, laboratory parameters. Most of the time in Indian setup, it may be difficult to do active surveillance. In small setups, resource-limited setups, you can try passive surveillance. Passive surveillance is you collect the data from the laboratory. Let's say they give a growth of ETA, aspiratus, Klebsiella, pneumonia. Then your ICN goes and sees the patient and collect the data passively. So ideal method is active, but you can try passive if you have a resource-limited setup. Once you started doing passive, project it to your admin and make sure that you need an active surveillance, get the manpower. That's the trick in it. Next is retrospective and prospective. That's again the same like active, passive. Maybe after a month, you get the data from your microbiology and retrospectively you can look at it. But there are a lot of drawbacks in retrospective. Interventions can happen only if you collect it in a prospective manner. Next is entire hospital versus specific patient population. Let's say if you have a 2,000 bedded hospital and you have only 2 ICNs, it's very difficult to capture the entire hospital data. But you can target at least the specific population group. Like you can target ICUs, you can target oncology units, transplant units. These are all the areas where you expect infections. So you can start with that and slowly you can move to the entire hospital. Then all infections versus specific infections. Sometimes there may be very, very resource limited area where you can't target all the pathogens. So you want to target only CRE. You can target only colistin resistant. You can target only MRSA. So that depends upon your institution how to start with the surveillance and how to go about it. But the gold standard is to do an active surveillance in a prospective manner. So next, this we always say this is called 5 P's of surveillance. So what is a basic thing that why we are doing surveillance? The first is it gives a baseline data. Maybe I'm just starting the HIC unit in my hospital. I will know what is the baseline VAP rate, CLABSI rate. So once after a month, I started implementing some bundle care, then I have to do the trend analysis and check whether there is a decline in the CLABSI, VAP and COTI rates. So this gives you a baseline data of your own hospital so that you can implement the policies and check whether there is a decrease in the infections. Second is, as I told, it helps you to plan, develop and implement policies individualized and customized for your hospital. The third is process outcome evaluation of the IPC practices is same. I will be showing a lot of graphs for that, so I'm not going to detail it now. Then prioritize areas, like you have only 3 ICNs. 3 ICNs cannot go to the entire hospital all the days. So you need to have a high risk areas or priority areas where the ICN has to visit every day. So based on the infection rates, you can tell the ICN that please visit this day, this particular area like neurosurgery ICU or oncology ICU every day as a mandatory. So then provide feedback, that is very important. We can't just sit somewhere and keep the data. The clinicians should be able to understand what we are doing. So these are all various surveillance definitions. Most of us use NHS and CDC criteria. The reason one that we are using is January 2024 guidelines. Every year CDC releases guidelines in the month of January. You have to update your IPC manual based on the CDC guidelines. The second one is a study that I have shown you by Puva Mathur et al., which is AIMS CDC ICMR network data. You can go through this website. There are a lot of freely downloadable checklist training PPTs are available. You can use it. It's a freely usable one by AIMS team that can be used it for your training purpose also. Then we have ECDC. Instead of comparing your data with CDC, of course we have to think up to CDC level, but CDC is more of a US data. ECDC is European countries, which includes developing countries also. So if you want to compare your data with external benchmark, you can still include ECDC and INIC data in your presentations in your HIC committees. So these are all the checklist. This is freely available in the internet, in the CDC website. Some institutes, they download the checklist, they use the checklist as such. But if you are already doing the surveillance, you know for each case you have to fill 7 pages, which is really difficult for the infection control nurse to do it. So in our hospital, what we have done is, we have adapted this form. So there is just a slight change in the form, but this will include all the parameters that we want for VAE, CLABSI, COTI and SSI. So in one form with front and back page as a sustainability, you should not waste pages also. The staff nurses will be able to take the form and fill it. The best way is to integrate your HIC data with the hospital information system and capture it as a EMR if you have an EMR. We don't have IP EMR, so we are using it in a paper form. So these are all the formulas. Please remember, do not have the denominators of patients. So what we are capturing is incidence per device days. So we are not looking at patients, we are looking at the device care. So the denominator is always device days. So for COTI, it's catheter days. So this needs to be collected every day. So if an ICU has 10 patients, how many patients are all on catheter? At one time point. So in my hospital, we have said midnight 12 o'clock, collect the data. So in your hospital, you can also keep one time frame across the hospital. Otherwise, what will happen? The patient will be transferred in the morning. There will be duplication of the data. So keep one time frame across the hospital, collect the denominator. The numerators will be collected by the ICNs and validated by the infection control officers. So there is only one difference in SSI rate. Here we are not looking at any devices, we are looking at the surgeries. So it comes as a percentage. So SSI divided by surgeries into 100, which comes as a percentage. So there are formulas available, how to do everything is available in the net. But more important is you have to standardize your surveillance. So even in Purva ma'am's paper, it's most of the data is from tertiary centers like JIPMER, PGI and CMC. But you may be working in a 100-bedded hospital or 50-bedded hospital. So you may not be able to compare your 50-bedded, maybe 50-bedded single specialty. So we can't compare the single specialty data with a multi-specialty data where the VAP rates will be alarmingly high. So standardize your surveillance. Please do not compare orange with apples. You have to compare apples with apples and oranges with oranges only. So one good way of doing is ECDC has a in-depth data. When you go into the Victor Rosenthal's paper, pediatric ICU VAP rates is given separately. Surgical ICU VAP rates is given separately. So if you have a surgical specialty hospital, you can compare your data with the particular rates. So go and read the paper and set a benchmark customized for your hospital. So make the key performance indicator targeted to your specialties. Always keep a benchmark. Please don't just collect data. Every year you have a target for you. So last year your VAP rates were 5. Whenever you're present in the annual meeting, you have to have a target less than that. And what are all the goals that you are going to have to meet the target. So that's the main aim of collecting this data. This is one of our data in the last year. So every month when you present, always present the previous month's data, compare it with your CDC and INIC and Indian benchmarks. And like you can see in the February, we had an increased VAE. So why there is an increase in VAE? Is it because of new staffs? Is it any issues or any cross-contaminations? So that you have to do the root cause analysis. Then every year you have to have a trends with the benchmark. So only when you plot the curve, you will be able to understand there is a peak or there is a decline. So what we did for the peak, that you have to retrospectively think, if you have forgotten something in that month, then at least for the next year, you should be able to do it. So plot the curve every month and present it and think and sit as an infection control professional what we have missed. Okay. So surveillance data is not just data. As I told, you need to do the root cause analysis. So let's say the CAUTI rates are very high. Why the CAUTI rates are very high? So you have to think and you have to look at the other data. So let's say neurosurgery ICU CAUTI rates are high. Get the data of hand hygiene audit, get the data of IPC audit and PPA audits from the same locality by the infection control nurses. Start doing a plotting of the curve. So this is not my data, but this is a very good study where they have done plotting of hand hygiene rates with the healthcare associated infections rates. So you can see when the hand hygiene is going up, the healthcare associated infections are coming down. So when you go and tell the clinician you have to do hand hygiene, they won't actually listen. I think you all agree with it. So you have to plot the curve. You have to tell them when you started doing hand hygiene, your CAUTI rates are coming down. Your length of stay of our patients are coming down. So patients are moving out of your ICUs because of you properly doing hand hygiene. So that kind of motivation with the data will help the clinicians to perform hand hygiene rather than just giving papers 60%, 70%. So that's very important. Give feedbacks. So this is one of our data. We give individualized feedbacks to each area, to each ICU, each oncology units. All the hand hygiene, this is a raw audit sheet. You have to use WHO audit sheet, which we have slightly modified as per our protocol. But if you are convenient in using the WHO hand hygiene audit form, you can readily download and use it. Prepare a audit report. So this is like one good audit report, which I have learned from CMC Vellore. So whenever you give it, just don't give the overall percentage, give the moment-wise reports, professional category-wise reports, which moment exactly they are lacking, which professional category exactly lacking, and give this report not only to the clinicians, to the housekeeping personnel head, to the physiotherapy head. So you have to give the report to every unit head so that they understand the importance of hand hygiene. And once you give it, get a feedback from them so that they feel responsible for the surveillance, they feel responsible for the audit. It's not only the infection control team who's responsible to do this. They also should feel liable to be giving a good data for us. Okay. So this is one of our PPE audit sheet. So you have a PPE audit data, you have a hand hygiene audit data, correlate that. So as I told, if the CAUTI rates are high, just sit back, spread out the sheets, see where hand hygiene is lacking, whether CAUTI bundle care is properly done or not, whether catheter care is done properly or not. Then go there and do the audit and give a proper surveillance audit report to the neurosurgeons. Okay. So that is about overall surveillance and root cause analysis. Sometimes what will happen, there will be a trend that you will pick up. Suddenly there will be increased MRSA infections in your hospital. Maybe post-operatively, surgical site infections with 3 MRSAs, or maybe a WAP with 2 MRSAs. So you pick a trend, something wrong, some cross-contamination occurs. So that is where you have to start doing MDRO surveillance. In abroad, routinely when the patient comes for admission, they do screening of MRSA, they do screening of MDRO, which is practically difficult in most of the Indian setups. So when do I need to start? I think my intensivist is here. So he also asked whether shall we start MRSA surveillance for all patients. Okay, you do MRSA surveillance. Where will you admit? Do you have a dedicated room? So those things need to be considered before you implement the policy. So if there is a problem, like you get 3-4 MRSAs in SSIs, then you have to screen all the surgeons. You have to screen all the nurses. Maybe the healthcare personnel is carrying the MRSA and transmitting it to the patient. So that time you have to do something called search and destroy strategy, where you actively do the surveillance within a time frame, pick where the source is coming from and destroy that. Okay. So that's the practical surveillance we can do in India. Then passively, when you get MRSA reports or Clostridium difficile reports, you can do cohorting or you can isolate if you have a facility for doing that. So this is one of the Clostridium difficile data. So in my previous institution, we had alerts. So any MRSA reports in the LIS, there will be an alert that pop-ups. So whenever clinician opens that, it will say contact isolation at CMC Vellore. In our hospital, we do a paper-based reporting. So whenever there is a MRSA or CRO, our ICNs will go and keep a paper of contact isolation in the case sheet. So even in resource limited setting, you still can do a colored forms. For MRSA, you can give a white color form. For CRO, you can give a blue color form. You put color tags, type it as CRO contact isolation. So once they open the case sheet, there will be a color coding which will be easily attractable, and they will know that this patient needs to be isolated in a single room. Okay? So this is about contact isolations that can be done with the help of your MDRO surveillance. The last 10 minutes is about environmental surveillance. I think how many microbiologists are here? Okay, Sumedh is here. Okay, so environmental surveillance is a key area for most of the microbiologists. So why are we doing this? Because as I told, the HAI comes from two sources. One is exogenous and one is endogenous. Endogenous is like MRSA, all those things that we talked about. Exogenous is the hospital environment. So we should make sure that our hospital is free from infections. We are not giving infections for patients. So for that, we have to screen all the sites. One is water, second is air, and third is hospital environment, especially the high-touch surfaces. Okay, so first is water testing. I'm not going to teach you how to do water testing. So there are a lot of methods that is available. Most of the times what we use in microbiology lab is multiple tube method, MPN method. So why are we doing this? First reason is portability. Like when we go out, we should be confident to drink the water. The patients who are coming to you should be confident enough to drink your water. They should not get waterborne illnesses like Vibrio, cholera, Shigella after admission in the hospital. So we should give a water which is portable, free from E. coli and other fecal contaminant pathogens. Second most common is the water that we used for preparation of pantry items, food items, dialysis. The water that we are giving for scrubbing in the OTs and ICU should be free of pathogens. So if there is a growth in the OT scrub station water, how will the surgeon will be confident enough to scrub and go inside? They will start fighting with us, okay? So then we have to advise them to use the waterless scrub or something, okay? So please make sure you have a routine surveillance protocol for your water, especially dialysis water, which should be free of CFUs and which should be free of which should be having the permissible limits of endotoxin levels, okay? So these are all the methods that is available. Most of the time the microbiology lab uses multiple tube methods, that is MPN method. The endotoxin level should be less than 0.25 EU. Most of the time we outsource it, some hospitals perform it. So this is our environment surveillance protocol. So in one way I can say, if you're newly starting to make up a surveillance protocol for your hospital, sit and make a list of areas where you want to have it. Have a frequency. If you're saying Wednesday, the whole hospital you're going to do surveillance, the microbiology lab will be overwhelmed. The technicians will not be able to prepare that much media. So you have to make a frequency. So monthly, first week these areas, second week these areas, third week these areas, fourth week. So divide it so that the load on the microbiology lab is less. Next is water sources. How many of you are doing water surveillance every week, every month, once in 3 months, once in a year? Okay, so why there is variations? Yeah, because there is no defined protocol. Okay, so you don't need to have a fixed protocol. Most of the time we do it in monthly. In my table you can see some are 1 month, some are 2 months, some are 3 months. So how did we arrive to this? Once you start, this is our new hospital which got opened a month back. So once you have a new hospital, the initial days you have to ideally start every month. So do it every month. Every month at least for 3 months. If you feel everything is no growth for 3 months, then you can switch over to 3 months once, or you can continue to have 1 month. So it depends upon your bed strengths, depends upon how much overhead tanks you have, so how much end user points you have. If there are too many end user points, too many RO systems, you can't have that much load. You don't need it also. If you have more infections related to waterborne, like you get a Shigella outbreak in the hospital, or you get Pseudomonas outbreak in a neonatal unit, you feel there is a problem in water, then immediately you have to do an outbreak analysis where your water surveillance comes into point. Okay? So to clarify, there is no defined time frame for water surveillance. It depends upon your institutional protocol. So these are all the environmental surveillance reports. Once the reports are done, please give a copy of the report to the environmental engineering or technical unit. A report should come to the infection control mandatory directly from the microbiology lab on the same day that they receive. If it comes after 2 days, then by the time we will not be able to take any actions. So the infection control nurse should go and visit the area. If there are any problems in the overhead tanks, you have to map your tank. From the tank to the end user, you should have a plotting of where the pipeline goes, what type of organism. If it's E. coli, then there's a fecal contamination. If it's Pseudomonas, then there's a water stagnation. So every point, trigger point of where is a problem will be based on the type of organism in the water. Okay, so that's about water surveillance. Next is air surveillance. Do we need to do air surveillance in ICUs? How many of you are doing settle plate in ICUs? Yes. Okay, how many times we open the door in ICUs every day? So many times. So there is no point in doing air surveillance in ICUs, routine ICUs, okay? Because there is obviously, there will be cross trafficking, there will be too many people coming, the air will be obviously contaminated. So you don't need to worry more about air in a normal ICU. We need to worry more in the transplant ICU, where we have immunocompromised host who will be prone for fungal infections. So air surveillance is only needed in BMT units, transplant ICUs, and isolation ICUs with negative pressure systems like tuberculosis units. So you can either use the old method, settle plate method, or if you have an air sampler, there are a lot of companies who give air sampler, that also you can do it. So this is a CDC data which says you do not need to conduct undirected microbiological sampling. So you don't need to do every week ICU surveillance, every week OT surveillance. You can have your own protocol. It's not mandatory. Some hospitals have actually stopped doing the surveillance also, stopped doing fogging also. So the last talk is about environmental surveillance. How the housekeeping practices is being monitored is by 4 methods. You can go and do a visual inspection, like cobwebs is there, dust is there, but that's not an ideal way. The second way that we are doing is fluorescent marking. You can put a fluorescent marker and check after cleaning it has been wiped or not. The best method is, as I told, ATP bioluminescence assay, but bit costly. Then the environmental surveillance swabbing. So utilize the digital platforms, give awards, appreciate them, put color coding like green is good, orange is okay, red is bad. You do award scoring, put it in your notice boards, so that the people know where they lie and they get motivated to move from orange to green. I have 4 more slides, shall I? So this is about legal aspects. If there are administrators, quality professionals, and microbiologists here, we talk more about surveillance data from accreditation point of view. I think we should think about legal perspective also. Most of the data says that we moved from communicable disease to NCD. Yes, of course we moved, but HA is a huge burden, and outbreaks becomes a pandemic threats like how we faced in COVID. Now there is a problem that lies as the legal issues. These are all few of the legal cases in India where the patient has filed a case against the hospital for hospital-acquired infections. One worrying word that I have read here is the complainant has alleged that the hospital provided adequate food and nutrition but treated the patient like a garbage that lead to hospital-acquired infections like Acinetobacter baumannii, Pseudomonas, Klebsiella. So this is a word the patient relative has quoted in the court, and the hospital has paid 12 lakhs as a penalty. This is not only in India. In US, each hospital is paying almost $1 million. So you can see the average payment that the hospitals are paying is around $300 million as penalty for bringing and giving infections to the patients. This may be the scenario in India in future. So we should be very cautious, especially if you're working in corporate hospitals. This is an eye-opener. You should have your data. You should make sure that your patient are not going away with the hospital-acquired infections and suing cases against us. So the last slide is, of course, after this talk, I can read your minds. It's easy to put up slides and talk. I have only one infection control nurse. I have one microbiologist, half a day sitting in lab, half a day going for rounds. It's practically difficult. Yes, resource limitations there, staffing issues are there, training awareness issues are there, behavioral practices. Talking to the admin and getting budget is really difficult. If there's a rock lying in the, you can use one man and try to push away, or you can try to chisel and break it, or you can use just a bulldozer and break it. So it's about you, how you think, how your admin is supporting you. You can break any challenge if you have a proper surveillance method, if you have a proper system and proper support. So I'll end my talk with a quote from Peter Drucker. If you cannot measure it, you can't improve it. If you're not measuring, please go back to your hospital and start measuring your data. Thank you.
Very good presentation, madam. In Indian scenario, I would say still we are lacking behind in many things. Like as you said, unless we start measuring, we cannot improve. So for that reason, even in my hospital, the same issues there. Forget about the ICO and ICN. This is only a matter of 2 or 3 staff. But when we go back to the ICUs, we see that the manpower is relatively, it is not comparable at all. I have like 15 beds in my ICU, and the nursing staff taking care is only 7 or 8. And in the night time, it will become further worsen. And also another thing I would like to tell here is that what we are focusing or what we are doing surveillance is a part of the ocean, I would say. Who is going to monitor in the night time about our hand hygiene practices, about our aseptic precautions and all. So we have started a concept of link nurses in our hospital, as all of us knows. We made in charges, or some of the nurses are responsible for monitoring the infection control practices. But still I would say the manpower is a major challenge, especially attrition rate in nurses is very, very high. Giving them training repeatedly, every time you see go back, you get a new faces there. So again, you have to train them from the scratch again, and they'll stay with us for some time, again they will leave. So this is going to happen, it is going to continue. Apart from that, equipments, maintenance of the equipments, environmental cleaning, as you said, it is a major challenge. You believe me, not only in the ICUs, even in the canteens, I saw cases who are ready to get discharged. Suddenly we get a call saying that the patient had diarrhea, and it is so severe that patient went into AKI. And that type of episode still happening in our hospitals. And when we go back and do the outbreak analysis, you believe me, I could not able to find anything. Either from the food, either from the water, or either from the surface sampling of the canteen or vegetable cutting area or storage area. Where is the culprit? God knows. And when we go back and interview the patient, have you taken food from the outside, or any attendant brought food from the outside? They said plainly, no sir. Whatever hospital is giving, we are eating that only. So this is like a very continuous thing. I don't know how to face this. Even with the nursing staff, you see, in the nursing hostel, every time 1 or 2 sisters will be having diarrhea, or they will be having fever. So when we go back and do the analysis, we are not going to get anything in that. So I don't know where we stand, but overall it was a very good presentation. Thank you so much for that.